from unceded and unsurrendered Algonquin territory. This is another virtual town hall from the First Nations Health Managers Association. Tanse, everybody. My name is Marion Crow. I'm back again every week sharing with our subject matter experts relevant, credible information on COVID-19 and a whole host of other things under that COVID-19 umbrella. Thank you so much, everybody, for tuning in to get your information here from the First Nations Health Managers Association. Thank you so much to the 150 Indigenous radio stations, APTN, you rock, for supporting this great sharing of our inherent knowledge and expertise that we bring through the guests every week. And I'm just so delighted to be welcomed into your nations and territories from wherever you are watching or dialing into or listening on that radio station. So this week, today, it's going to be a great hour, as I tell you every week. Go get your lunch. We were talking about Bannock on NCI radio this morning in Manitoba. So I know what you guys are having for lunch there. And sit back and let's share some knowledge today. On the town hall, we are welcoming back our great friend from Indigenous Services Canada, Pamela Wolf-Roberge. Pam, you're going to give us those epi stats in a couple of minutes. And I am so happy to have brought in Dr. Alika LaFontaine. Alika, my fellow prairie person, we're probably cousins, I'm sure. Dr. Alika LaFontaine is going to be talking to us about safe spaces. He's going to dig into that, provide some comment on some of the anti-Indigenous racism in the healthcare setting as well, and a really great tool for us to be able to share some of our stories across Turtle Island. Dr. LaFontaine is an anesthesiologist. He's an Inspire Award recipient, and he's here on the FNHMA Town Hall. So let's roll up our sleeves. You know the drill. If you have a question for Pamela, Alika, or for any other guests that we have coming up, please send it in to fnhma@ihtoday.ca. Pam, you ready to come on into our virtual space and share the epi stats this week?
I'm ready, Marion.
All right. Well, welcome back, Pam.
Thanks, Marion. Thanks again for having me here at FNHMA. It's always great to come back and to share the latest information with you as we're seeing across the country for COVID-19 and First Nations living on reserve. So as Marion noted, I'm the director of the Communicable Disease Control Division at Indigenous Services Canada. I grew up outside of my community in Ottawa, but I'm of mixed background, and I'm originally from Jibasing First Nation, or a member of Jibasing First Nation, located on Manitoulin Island in Ontario. I'm joining you again today from my spare bedroom on the traditional and unceded territory of the Algonquin Anishinaabe people here in Ottawa. So today I'm going to share with you an update on what we're seeing in terms of COVID-19 infection among First Nations living on reserve, as well as a brief update on what we're seeing in terms of the vaccine uptake to date. So as of yesterday, February 17th, for COVID-19 infection among First Nations on reserve, we saw a total of 19,361 cases. But of those cases, we've seen 17,803 recover. So that works out to being 1,350 active cases. Those are the cases that are remaining in play, that those people are still able to transmit that disease to others, and that's across the country and communities. And of those total cases, 898 have been hospitalized and 208 have passed away. So I was here a few weeks ago, and I would say that as it relates to the comparison to the general population, we haven't seen too much movement. Hospitalization and death rates still remain lower among First Nations on reserve than they do of the general Canadian population. while the overall case rate of COVID-19 infection is a bit higher, we're looking at it's about just slightly over 1.5 times the infection rate for the Canadian population, or the general Canadian population. In terms of the hospitalization rates, so I mentioned that the hospitalization and the death rates continue to remain lower among First Nations living on reserve. So that works out to being 4.5% of COVID infection resulting in hospitalizations for First Nations. And if you're looking at the general population, it's higher at 7.7%. In terms of the cases that have unfortunately passed away due to infection for First Nations living on reserve, we're sitting at about 1% of all those infected with COVID-19 versus 2.6 among the general population. So that's the percentage of people who've unfortunately passed away due to COVID-19 infection. So we continue to see preliminary signs of hope. We're seeing case counts overall in Canada start to drop. And as it relates to First Nations communities, we've also started to see the number of communities with active COVID-19 cases decrease. So for example, in the first week of February, we saw 253 communities that had active COVID-19 cases, whereas last week we saw that number drop to 135 communities. But it's important, even in light of this, that we do not become complacent, because we know that COVID-19 is still there and people are still getting sick. Many of the new cases that we are seeing are still linked to small and larger gatherings. I think we know that in these types of settings, especially more smaller and informal, I think actually all gatherings, but I'm thinking more in small and informal gatherings, maybe you're with friends or at a friend's house or a family's home, we tend to let our guard down and maybe not practice the public health measures that we know will keep us safe. And like I said, COVID-19 is still here, and we know that with the introduction of variants of concern in Canada, so these are the variants that we're learning about from the UK, from Brazil, from South Africa, that it's important that we do not become complacent, that we definitely continue to follow those public health measures. We know these. This is, practicing good and great hand hygiene, so washing your hands frequently or using hand sanitizer. Wearing a mask when you can't maintain a safe distance, and also consider wearing a mask in any indoor space, but also those spaces where if you're inside with somebody from outside of your household, it's good practice to just make sure you're always wearing that mask. Avoiding gatherings, again, as I mentioned, I think a lot of the cases we are seeing that are still linked to small and larger gatherings. And of course, staying home if you're feeling in any way sick. Better to be safe than sorry, and to stay cozy at home than get out and risk potentially making anybody around you sick. As it relates to vaccine rollout in Canada, we've seen as of February 12th, so that's of last Friday, over 400 communities who had started their vaccinations. Vaccination campaigns have started in communities. It'll vary. Some are focusing on just priority groups, and in other cases, we're seeing communities that are able to immunize the entire communities across provinces and territories. I think if you've already had your vaccine or not, I wanted to share that we are starting to hear from some people that they're reporting experiencing some side effects after the second dose of the vaccine. And I wanted to let everybody know that this is normal and this is to be expected. So side effects like pain, redness, swelling, where that needle is given in the arm, mild fever, tenderness, those types of side effects are normal. And that's actually a good thing, because it means that your body is ramping up and it's reacting to the vaccine and building those antibodies that you want. I know this year when I got my flu vaccine, I always get it in my left arm because I'm right-handed, and it's about two days of that tenderness and a bit of a sore arm. But for me, it reassures me knowing that my body's doing what it's got to do and it's activated. So I just encourage everybody here, making sure that they continue to source that information from trusted sources as it relates to the COVID-19 vaccine, so that when it is your turn to get the vaccine, you feel confident in the decision that you're taking. And also, if you're looking for a trusted source, on the ISC website, we've actually just launched an awareness webpage, and it includes a variety of COVID-19 resources, but also includes a one-pager about what you need to know about the COVID vaccine. So it's a great landing page in terms of trying to find out that additional information that you're looking for to help you understand more about the vaccine and feel more confident when it's your turn to get the vaccine. With that, Marion, I'll pass it over back to you. Thanks.
Thanks, Pam. We always appreciate hearing those epi stats and where we're at. I know that variants have now been identified in Indigenous communities as well. And I just want to give the whole audience, everybody listening, everybody watching all the live stream right now, if you have a question about the variants, and we all have questions, I have a million of them myself as well. We're dedicating the whole hour next week to discuss what those variants are, how you need to think about protecting yourself and others, just like COVID-19. This is another variant that's come in, which is alive and well in our communities now. And unfortunately, with all the social determinants of health that we face in our nations, this is going to be the next battle that we are going to face together. So continue to stay safe and stay well and protect you, your cookum, your aunties, all of those folks who are in your nation. And I know that Margaret King says, Chi to all the frontline workers. Thank you, Margaret, for sharing that with us. Yvonne, hello back to you watching on Facebook. And Michael, a big tanse and Ani to you. Alfred, I know you're watching from Calgary, so you must be here to see Dr. LaFontaine. I do want to note too that we have a stat here that's also from Indigenous Services Canada that more than 78,000 doses have been administered to Indigenous communities. So thankful that 78,000 more people are protected with that first dose for now that we know of, and we'll keep bringing those stats to you every week. Now, if you have other questions that you don't want to send to fnhma at ihtoday.ca, you can also call or email us at FNHMA and utilize our info point services. Kathy Mitchell, one of the FNHMA staff who's from Segmuck. Hey, shout out to Segmuck, Ontario First Nation, and to Kathy Mitchell. We want to share a bit of information about InfoPoint. Chris, take it away in the studio.
Created by your First Nations Health Managers Association, we introduce InfoPoint, a convenient and accessible helpful desk for First Nations health managers looking for credible sources of information on COVID-19. Don't have time to dig? Talk to a real person now at 1-855-446-2719 or email infopoint@fnhma.ca. Indigenous Health Today is another resource of information by region at ihtoday.ca.
And thanks to that studio for giving the message on InfoPoint. We're here to answer those calls and emails. So again, run over to your computer, send in a question at fnhma at ihtoday.ca. Now, without any further delay from me, you've heard my voice enough. I do want to welcome a first-time guest. I'm sure it's not going to be the last, Dr. Alika LaFontaine. Alika, welcome to the First Nations Health Managers Association Virtual Town Hall.
Thanks for inviting me. This is amazing.
It's so great to have you here, Alika, for a whole host of reasons. I know you're going to chat with us about safe spaces, and I have to say the feedback from the FNHMA Board of Directors was fantastic when you had presented to us not too long ago. So why don't you share what's keeping you busy other than, being an anesthesiologist in the operating room?
Yeah. I'll share a little bit about my own experiences with COVID as a frontline provider before kind of dipping into that. Some of you may know what anesthesiologists are. I tried to figure out a quick way to explain what we do, and I came up with the term medical ninja. So we're highly specialized, we're very mysterious, and we're the last thing you see before you lose consciousness. So we're the folks within the operating room that help to keep you asleep and pain-free and comfortable as you come in for different surgical interventions. And we're also there to help with chronic pain. We help with labor and delivery. Some of you may have had epidurals before. But as a frontline provider, we're exposed to situations where passing along COVID is actually very, very high risk, probably the highest risk out of all the different types of physicians that you meet in the different places you might meet us. And I remember when COVID first came out in March, and myself and a lot of my colleagues were actually sleeping in the garage because we were afraid of what would happen if we came home to our families and passed along this virus that we didn't know a lot about. And I just have to say that these types of opportunities to share knowledge and learn things from people that are right in the midst of things and not just dropping in, but are a part of your show over, a long period of time, that fear that I had early on, I was able to kind of frame that in with knowledge, knowledge from people that I know that I could trust. And this whole experience has been very scary. And I think that there has been different messages from many different people about how to approach this virus and keeping each other safe. It's important to make sure that we pay attention to voices that we can trust. It's important that we listen to voices that are our own voices, our own Indigenous experts and representatives within government and the health system. And this is the way that we're going to get through this together. When we finally start getting a handle on this in the summer, and I myself have had the opportunity to get vaccinated because, like I said before, we're part of that high risk group. And so we were in phase 1 in most of the plans across the provinces. We realized that we can get a handle on this virus if we do a series of things consistently over time. And so you heard from Pam and you've heard from Marion and other guests over the past few weeks that, washing hands, making sure that you cover your face with a face covering, preferably, a surgical mask, but if you don't have that, some other type of face covering, trying to stay within groups of people where where each other travel and who you speak to, the bubbles per se that we talk about, and then trying not to mix as much as possible. That way we don't become unaware passers along of, this disease. We will eventually make our way out of this. I think there'll be lots of questions about vaccinations, which I'll leave to a little bit later, but we will make our way through if we take care of each other and making sure that we follow public health guidance. And when the opportunity comes to become vaccinated is part of taking care of each other. And I love hearing these messages over and over again. So Safe Space Networks is a project that I became a part of a couple of years ago. It was actually triggered by an experience that my brother had. And me and my brother have been working on this for the past little while. And so he phoned me in the middle of the night. He had been having abdominal pain for the past day, came into emergency, and like everyone, sat there for a few hours and then was eventually seen. And he was really concerned that the feedback that he got from his medical provider wasn't the actual problem that he had. And there were a few reasons for that. But when he got onto the phone, he said, bro, I want to know, what do you think I have? And so this was a big moment for me. My brother never asks me for advice. And I don't know about the rest of you, but I have the doctor name, but my family doesn't necessarily trust what I say any more than the average person. So we kind of went back and forth, and it became pretty clear to me, at least, that he had, a common medical condition called appendicitis. So part of your bowel gets inflamed, and it happens from time to time. And he told me that the medical provider had told him something different. They had given a different medical diagnosis. And we went through step by step the decision-making approach that the medical provider should have taken. And I, of course, was able to share this because of my background in anesthesia and as a doctor. And what I found out pretty quickly was that there were many different things missing within that interaction. It was a very brief conversation. There wasn't a lot of medical history taken. The provider had not done a physical exam. There had been no lab work that had been sent off. Usually you send off for either an ultrasound or a CT scan, which is kind of like a fancy x-ray, and you use those together to make this diagnosis. And the diagnosis that he had been given was one that if he went home and it was this more concerning diagnosis based on our chat, he could have gotten really, really sick. And so when I told him about all of this, the first thing that he told me was, bro, I'm really concerned about what will happen if I challenge this medical professional, if I tell them that I don't feel that this is what I have and I want a second opinion. He was concerned about the conflict. He was concerned about being labeled as a difficult patient. He was concerned that if he left and then came back again sicker, that they would remember this interaction and that would lead to worse care. And I had trained in Regina. I grew up in Treaty 4, and I trained in Regina hospitals, which is where he was at. And I actually picked up the phone and I was able to call a couple of people, and he ended up getting reassessed, and he went for emergency surgery because it actually was appendicitis and it had ruptured. So, I mean, he could have died if he had gone home. And I remember talking to him the next morning after all this had happened, and there was a line there that really stuck with me. He said, Alika, at the end of the day, it doesn't matter what I've accomplished in my life. When I put on that hospital gown, I'm just another Indian. And that really stuck with me and led to a lot of different conversations about racism and discrimination and bias, and how, because of my role as a physician, he was able to navigate some of those systems. He was able to share his story and actually get people to act on it in a different sort of way. And that's where the whole idea of safe space networks came. We all have our own stories, but when we share them, it doesn't necessarily lead to any difference in how we're treated. There's so many things that have happened in the past year with regards to anti-Indigenous racism. There's been horrible experiences that have been very public. Joyce Etchikon in Quebec and the experiences that she had, that she live streamed on Facebook, other experiences that patients across the country have shared in news media. There's a big movement within the health system to finally acknowledge systemic racism. I won't really say that it's being addressed, because it's not addressed unless people who are listening to this actually feel that it's addressed. So until you feel that racism is resolved, it's not resolved, And I have a lot of excitement about what's going on. But unless we, as patients and community and, Indigenous experts and colleagues within medicine all start to tell kind of the same story, it'll be difficult to keep the momentum. The system's really good at acknowledging emergencies, things that spiral so far out of their control that they can't grasp hold of it anymore. When Joyce live streamed her experience, that was a moment that no one could manage, right? It was raw, it was real. Anyone who looked at it realized that was just not the way that people should be treated, no matter who they are. And over time, that sensitivity to that story, it'll change. It'll soften and it'll de-escalate. And I think we have the opportunity as Indigenous communities and supporters of each other to really make sure that we keep the momentum going and that these stories don't get lost. Patient harm is the third leading cause of death in Canada. I think for many people, that's a surprising statistic. And when you go for medical care, on average, 10% of people actually run into some sort of medical harm. So that means that you stay in hospital longer than you should, or you end up leaving hospital with something that limits your ability to live day to day. It makes you modify kind of your activities of daily living. And when these things happen, we all sit back and we ask ourselves, should I report this? Is it bad enough to report this? And I think the reason why we frame it that way is there's a lot of fear that comes into reporting harm. You could get retaliation from your provider, like I talked about with the experience with my brother. There's further hostility from the health system. You may go through reliving the harm, but not necessarily generate any sort of change, you know. And then it's not knowing where to start, because sometimes the system is very confusing. You share your concern with someone who's a health provider, and then you find out, oh no, I have to submit an official document and I have to call it a complaint. Maybe I just want it to be called a concern. Then you find out that there's another person that you need to report to, and then that person doesn't take your complaint. It goes to another person, and suddenly you get trapped within the system where you feel like you don't own your story anymore. You know, your story's out there, but it's not under your control, and you've just exposed yourself to all of this harm. That doesn't mean that we don't share our stories, though. You know, when we have harm happen to us, we share them with our family, we share it with our social circles. I find more and more that we're posting on Facebook about our experiences. Patient advocacy organizations like First Nation Health Managers Association, I imagine, receive a lot of these stories. We're doing a big project in BC with Safe Space Networks right now, where friendship centers are helping to gather and share these stories. And patients want, my brother wanted, just to avoid new harm. You know, he didn't necessarily want to have the person who shared what happened or that did this to him to be disciplined or other things. He just wanted better care, you know, and he wanted to make sure that he could avoid new harm in the future. And so what Safe Space Networks is a way to look at concerns, and if we want to label them, complaints, in a different way, and to not have them trapped within the system where we're forced to lose control of our stories. You know, one of the persons that we talked to when we're going through the original design of this, they said, you know, the system swallows my truth, and then it's not my truth anymore. And so when you submit a concern or complaint within the health system, you report, you expose yourself to that harm, and the system really puts the burden of change on your shoulders. You know, you have to feel like it's so bad that you're willing to risk it all. And then you move into these confidential, siloed investigations where you don't necessarily hear anything, but they go through a process, or at least you're told they go through a process, and over months you eventually hear something. In systems where racialization is systemic, punishment doesn't necessarily lead to change. And so with the example of Joyce, you know, they fired the health providers that were a part of the incident. But in a system that normalizes treatment of patients and normalizes racism, it will eventually create another person who just is who racializes patients as well. And so what Safe Space does is it's a way to share anonymously your story, and for it to be captured and then combined with other stories so we can discover patterns. And those patterns are then validated through a series of steps and connections within the health system. And once we have some confidence in the repeatability and reliability of these stories, we then share them with the health system and with patients so we can all make better decisions. You know, as a patient, if you know that going to a clinic, you might be exposed to a racialized encounter, you know, you might experience racism because someone else experienced it. You can avoid that clinic, you know, or you can be empowered on how to work through those types of conflicts and those types of interactions in a way that leads to better care. You know, sometimes when patients ask me, well, how do I deal with the racist doctor? I often tell them, you know, tell them that they're being racist, but say it in this way. You know, use these words. Frame your story in this way, or emphasize this part of your experience. Sometimes it's not the content of what we share, it's how we share it that really changes the way that the system responds to things. And then the system really wants to actually do a better job. You know, I would say that I've never come across a provider that really says, you know, I just wish I harmed an Indigenous patient today, and that would just be the best day. You know, people don't want to harm patients, but we live in these colonized systems where we've normalized behavior, and normalize this harm. And, hearing your stories and having them, structured into these patterns is a way for them to make better decisions and become aware of things without necessarily having complaint hung over people's heads, And so the whole idea behind safe space is safe sharing, pattern generation, and then making better decisions and supporting patients in the health system in order to do that in a better way. So there's a variety of different ways that we collect the information. We're in the information gathering phase right now over at BC AAFC. If you want to visit the website, it's safespace.healthcare/BCAAFC, or you can go to the BC Friendship Center's website and click on Report Racism. We're also talking with Marion about creating a way for First Nation Health Managers Association to actually collect these stories as well. We're going to start having, these Zoom chats or audio chats where people can share their stories anonymously. You can have confidence that as we take your stories and as we organize them into patterns, your identity will never be shared. We actually designed the entire process around making sure that your identity isn't shared. That way you could protect yourself. And as far as the ownership of the information or where this information goes, within Safe Space, we use it to generate the patterns. But one of the strong commitments that we have in our approach is to provide that information back to the advocacy organization that you shared it with in the first place. One of the things that we need to have before we have reconciliation in health is to make sure that the truth gets out there. And the faster the truth can get out there and the more we can keep people safe when they share the truth, I think the faster we can actually have a lot of these changes happen. So thanks for the opportunity to share. Happy to answer questions about Safe Space networks and also participate in the conversation around COVID today. Thank you.
Dr. LaFontaine, thank you so much. I'm getting messages coming in. We monitor Facebook, obviously, and are watching the inbox. I know that there's going to be a lot of folks who have some comments. Please feel free to get those in now, guys. fnhma@ihtoday.ca. A lot of comments, though, that pulled at our heartstrings, Alika. These are stories that we all carry. I myself, who like to think I'm knowledgeable in First Nation health, somewhat am challenged with how to position things in a mainstream environment. And for our radio listeners, I was air quoting our mainstream health services. And it's really unfortunate. NCI Radio asked me this morning, Marion, what do you recommend? And have you heard anyone? And thanks, Alika, because of something you said, I was able to respond with, we have to have strategies. If we think we're going into a healthcare provider or organization where we think there might be racism, either we hear it in the Moccasin Telegraph or through one of our family members. And some of the strategies I shared, and I welcome you, Alika, to add on to them, but to take somebody with you. I know it's challenging in COVID right now, but normally it would be great to have somebody to hear what is being said. A lot of times you're receiving information that is about you not being well. And so to have a second set of ears to listen to what's happening is always good. Look for those ambassadors or a patient navigator if there is one in your health setting where you receive care. And Alika, I welcome you. If there's any other strategies that, and first I want to acknowledge before you comment, Alika, is that yes, this is where we are. Yes, we have strategies on how to receive safe care. And it's a shameful and sad day that in Canada, Indigenous peoples have to think about this when entering the healthcare system. Alika, do you want to comment a little bit more about that?
Yeah, I think there's a couple layers there. I think the first is the whole experience of care isn't really well designed. When you come in and you get a diagnosis that really changes the way that you have to live, whether it's diabetes or high blood pressure or asthma or cancer. These are situations where, as you're receiving the information, there's an emotional response that you have as well. You have your concerns as you're trying to listen to the person who's sharing things, and having a second person there to kind of share that experience and help absorb that information, and who's really focused on getting the content out of the doctor, who's a little separated from the experience. It is really important just to make sure that that knowledge exchange happens. You should walk out of your doctor's office or your encounter in the hospital having a clear idea of what exactly is going on. And I'll just underline again, we do a really bad job at this day to day. So it's not you, it's us. And we have to change the system to make this better. The second part when it comes to racism is that having a second person there can be quite helpful. I think what could be even more helpful, and one of the reasons why we designed Safe Space, was making sure that your social network actually shares with you the experiences of what goes on. Just speaking specific to, remote experiences of Indigenous people, if you live in a fly-in community where a locum comes and visits, a very common experience when I talk to colleagues is that no one comes and sees the locum if they're new until someone goes and has a good experience. And then suddenly everybody comes and starts to talk to this locum. And there's two parts to that. The first is that the locum should know, the visiting doctor should know, that they have to gain the trust of the community. They can't just drop in and expect people just to trust the doctor or the nurse practitioner because that's who they are. So that's one place where we can cause major change. The second is that if we can accelerate how quick people know about the good or bad experiences that happen, the faster people are going to actually get the care that they need and navigate around those types of care. And that's really what the network is built around, a learning system where we can exchange knowledge and then make better decisions. When you're in a situation where addressing racism, I would say just in general, I'd use terms like communication. I don't feel like you're hearing me. I don't feel like you trust what I'm saying. I talk about your own experience and you understanding your disease. I would actually say out loud, I do care about how my body works. I care about my health. These are all things that directly push back against the myths that people project onto us when we come for care. That we're disinterested, that we don't care whether or not we're healthy or not healthy, or that we're going to go home and not, follow advice or help the advice inform what we're going to do when we go home to our family. And I can tell you as a medical professional, but also as a patient, and as a father who's gone in with my own kids for medical treatment, this is all real. I've experienced the same things that you've experienced. And I mean, in residency, they always thought I was security when I came to help with anesthetics, because that was what people projected onto me when they saw how I looked and they saw what they thought I was. And so these are challenges that I've gone through and that you'll go through. And if we share back and forth, we'll be able to go through it much better.
Alika, those are such powerful messages. Many of our listeners and viewers are really tuning in to what you're saying. Somebody said, can we clone him because he is so profoundly wise? And Alika, I do want to say, can you also share with us again the website? Because Carrie Nash, who's on Facebook watching, hi, Carrie, says, thanks for an amazing truth for clarity and better health. And I love that she used the truth, because that's what we're sharing is our truths and owning our stories. So, Alika, where do we look again for more information? I know you talked about BCAFN and...
Yeah, so if you go to the BCAAFC website, there'll be a link there that says Report Racism, and that'll take you directly to the landing page with the kind of intake survey. You can also visit the link directly. It's Safe Space, SAFESPACE healthcare, HEALTHCARE /BCAAFC. And like I said, we'll be working with the First Nation Health Managers Association to create their own page, and we'll be opening up Zoom rooms as well as audio only rooms for people to share their stories live as well, because I know sometimes people either don't want to type. Sometimes it's more natural just to share your story just by speaking out loud. And sometimes, especially for our elders, it's easier to talk and share and kind of have a back and forth versus being forced to type. So we're going to try and open up all those different ways for you to share your stories.
And that's right. Everyone tuned in to this FNHMA Town Hall. You're hearing it first. You're hearing it now. We look forward at the First Nation Health Managers Association to provide another support, a support that really touches your lives, a place where you can share safely, safe space, your experiences with your nations, your community, and with information is power, and we can identify and look at those patterns, as Alika said, about what's happening. Now, Alika, I'm kind of keeping you on the spot here. It's just so welcoming to have you here as a doctor, as a fellow Treaty 4 grower upper. We had chatted once about high schools in Regina, and I was a Tom collegiate girl, and Alika didn't go there. He went somewhere else that I won't say, but I have to lighten it up a little bit here, right? I know folks are crying right now, so I need to, come back a little bit. Alika, you attended and presented on the First Nation, on the anti-Indigenous racism meetings. We had Jocelyn Forsma last week with the National Association of Friendship Centers, who talked a little bit about safe spaces as well. But what were some of those takeaways with your lens as a physician who's experienced racism, has quite a bit of knowledge and inherent knowledge, I will add? What were your takeaways on those meetings?
Mm-hmm. I think it's important for listeners to remember that these meetings aren't really where things happen. It's the stuff that happens between the meetings, both before and after. And so the real threshold of change will depend on what happens from now. I think there was some amazing, deeply held truths that were shared at that meeting. And I think that there was a lot of space that was left open for people to really just share what they had been experiencing. When you look at advocacy in any issue within Indigenous health, we live in this structure where we share our truths, and then the system forces us to kind of fight against each other because we're told that there's not enough money, there's not enough time, there's not enough people. And that back and forth is something I think we inherited from colonialism, because it was a way for us to be weakened when it came to, our inherent rights, as well as, our stewardship over the lands and territories that we live in. And this is an opportunity, I think, for us to move beyond kind of the competitive advocacy that we have. Day one of the national meeting was a really great sharing moment. I think day two, we started to get into a bit of that competitiveness back and forth. If only you did what I asked, everything would be fixed. I think we can sit back as, our nations and our communities and see the big picture, and really interject our philosophies and teachings into how this needs to move forward. There's things that have to change within racism. We have to make sure that it's not acceptable in any situation. So there's clear roles for, regulatory authorities to actually get people who have expertise in knowing what racism is. The days of having someone who's never been racialized as a non-person of color telling you whether or not you had a racist experience, those days need to just be done, and they need to be done today. Whether or not you experienced racism is whether or not you say that you experienced racism. So that's kind of the first part. I think the second part is understanding what the impacts of that racism is. In the story that I shared about my brother, and I'm sure a lot of you who are listening have experienced these things as well. When you have denial of care, when you're not given all the different options that you can be provided, when you're not assessed and worked up the way that everybody should when they come with medical conditions and symptoms and signs, that falls below the threshold of what's acceptable in medicine. Other things like being upset that you had to wait a few hours in emergency when it's actually the same amount of time as everyone else who had to wait, not being able to get a call back as quick from your provider as you want. These types of things we have to differentiate. There's negative experiences that aren't racist, but all racist experiences are negative experiences. And so teasing out those two things is really important, and having communities and patients help the system understand what is what, and making sure that we all kind of move towards the same narrative is another big change that needs to happen. There's a lot of movement that's happening after those meetings. The National Consortium on Indigenous Education, which has amazing people like Lisa Richardson and Marsha Anderson, as well as other Indigenous educators and leaders. That's going to cause major change within medicine, and I'm a part of that push over at the Canadian Medical Association and the Royal College of Physicians and Surgeons. Having Indigenous patients say out loud more and more about their experiences, I think will accelerate it. People are sensitized now. So when you challenge the system and say that, I had a racist experience, it's not like past days where they said, well, I don't really think racism exists. People have to acknowledge it because of the space that we're in right now. And having the government come out and actually say that they might tie funding to dealing with racism, I think is a pretty strong statement. Two things that I'll warn about is, number one, the status quo is really good at reframing new problems with old solutions. So fairly quickly, racism may become just a continuation of whatever the approach was in the past. And if the past approach didn't work, it probably won't fix racism, in my opinion. The second part is that as we take over the responsibility for our own healthcare through transferring these programs to communities, it's really important to get a clear idea of what a health system is. And this isn't something that any patient should be expected to know. There's all these different components: quality improvement, assessment, regulation, accreditation. I mean, Marion, you've been in this space forever. That our communities need to understand, because once those responsibilities get transferred to you, you'll have to do those things, and sometimes the funding envelopes will be too small, and sometimes the responsibilities actually fall on existing bodies that are just not doing their job. And so making sure that we have a clear understanding of what a healthcare system is, I think, is really important, and more now than ever. We need support for training. We need support for skills development. We need the government to provide, the opportunity for people to learn these skills in an organized way. And I think I see a lot of support from Indigenous Service Canada in this area. Obviously, First Nation Health Managers Association, this is something you do extremely well. And making sure that we support those things going forward is going to be really important.
Thank you so much, Alika, for just all your wisdom and knowledge that you're sharing with us. On that note, Pam was talking about the effects of immunizations, and I'm kind of stealing you a little bit. You were here to talk about safe spaces, but hey, you're an Indian doctor. We've got gold on the program here. And our Indian, not the Indian, as I think we all know that now. Alika, you've had your immunization. Am I correct in saying that? And if so, Tell us about that experience, because a lot of folks back home are scared. I mean, we know the colonial history and the relationship, especially when we look at vaccines and immunization. But why should we be excited about this? Tell us your experience.
Yeah, so the fear that you have is real, and it's a fear that I shared. And like I said before, the cure for a lot of fear is knowledge and knowledge exchange. So these vaccines are based off of a process. The mRNA vaccines, the process has actually been around since the 70s. It's a new application of an old technology. So when we talk about new vaccines, they're not a brand new something we just thought up, in the past year. It's all built on really good science. Um, the research around the two main vaccines that have been distributed thus far, the Pfizer and the Moderna vaccine, uh, are really exciting. After your second dose, you can get up to 94, 95% protection. Uh, the experience of getting the vaccine is very similar with the first dose to getting a flu vaccine. You can expect a little bit of soreness on your arm. Uh, you may read around on the internet uh, of something called COVID arm. That's at least what they're labeling it as. It's just extreme soreness in your arm. So some people react to the flu vaccine a little bit more than other people. Like Pam said at the top of the program, having these sorts of responses is actually good because it's showing that your body's reacting in some way, and your immune system is acting in some way to being presented with this vaccine. The second dose, which I had 3 weeks after, it affected me a lot more than the first dose. I had a bit of a sore arm the first time. The second dose, I actually probably shouldn't have gone into work. I was extremely tired, and I had a headache, and people were telling me, you need to go sit down. You look really tired, and that stuck around for about 24 hours. And after that, I had this peak of energy. Um, and I think that was just my body responding to this brand new, viral load, this brand new immune response that I was having. I went around and did a poll within our department, and I actually found, 80% of the people that I work with actually ended up having extreme fatigue after getting the second dose. Not a single one of them had this last longer than 48 hours. I think reading through the literature, it's clear that there is a proportion of people that do react strongly to the second dose. It is your immune response. It is normal. It is something that's expected. And your health providers are going through it too. So if you do feel extremely fatigued, or you develop some symptoms where you have, a runny nose or a cough or soreness or other things, just keep an eye on it for the first couple of days. Make sure you drink lots of water. Make sure you get some rest. Don't operate heavy machinery. And it'll eventually pass within 24 to 48 hours. But I have a lot of confidence in the vaccines. I think that the reason why they've come out so fast is because for the first time in human history, we've had the entire world looking at the same problem. And so this is what happens when we all come together and try and solve a problem. And so I'd have a lot of confidence in vaccination, and I encourage everybody that I talk to get vaccinated.
What a powerful, powerful, and moving story. For those of you who are just gathering the information now so you can make an informed decision on whether or not you want to be vaccinated, I hope this helps you in shaping your decision. Again, knowledge is power, and the more we know about something that's going to be put into our bodies, the better. And to hear from a trusted, credible source. We're just so fortunate, Alika, that you shared that experience. Um, Pam, I know we were chatting a little bit last week about where immunizations are at across Turtle Island. And it's important to note for all of our listeners and viewers that it's not an Indigenous Services Canada lead. And do you want to share a little bit more? Because I really feel that Indigenous Services Canada has done an amazing job in disseminating information, participating here in transparent information sharing, but it's the provinces, right, Pam?
Yeah, Marion. So whether it's the COVID vaccine or regular vaccines, I think one thing to remember about the COVID vaccination campaign, and you've heard it before, this is the largest campaign we've ever done in our history in Canada, and I'd say globally as well. So part of the trick to this, and I think about rolling it out, is building on the current infrastructure that we have. So what do we know that works in terms of delivering, getting it into communities and administering it? So say if it's the flu vaccine or other vaccines, every year the provinces and territories will either procure their own vaccines. In this case, vaccines were procured by the federal government and then distributed to provinces and territories. And from there, provinces and territories worked to allocate those doses. So in this first quarter, you heard Alika speak about healthcare providers, how they were prioritized. So there was national guidance on those populations who were at risk of either transmitting the disease or the infection, and also who were at risk of more severe outcomes. So some of our seniors or elders, and those who, just those who are those higher risk long-term care staff, residents, healthcare workers. So, and all that to say, provinces and territories were allocated a number of vaccinations, and from there, I'd say building off those national prioritization guidelines and also looking within their own jurisdictions and at the attack rate, then they further allocated and then would work to distribute those to communities. So I'd say where ISC and where communities or where ISC has a role is really supporting communities. So where we provide direct service delivery, or where we fund band staff and band nurses to help support them in having a vaccine clinic. And also, as Marion said, I think facilitating discussions and building linkages between provincial and territorial colleagues as well as partners, so that partners are included in those planning discussions, and provincial and territorial bodies understand, I think, what those perspectives are, and it helps to inform them in their allocation and distribution of vaccines.
Thank you again, Pam, just for pointing out that clarification. I know a lot of folks are keen and anxious. Numerous chiefs have been asking for the vaccination, especially now that we have variants on Indigenous, like in our nation. So it's really appreciated that we put that point of clarification out, that it is a provincial battle that we're having right now. Alika, we're just going into the wrap up. I can't believe how fast this hour goes. But Alika, did I hear that maybe you are running for something? And can you just tell me a little bit about what you're putting your good name forward for?
Yeah, so I don't normally run for political positions, but the Canadian Medical Association president-elect campaign's ongoing. I did put my name in for that. What's happening is Alberta doctors are voting right now to select the president-elect that will be a representative of not only Alberta, but all of Canada. And for the first time, we have Indigenous candidates within this election. So I'm pretty excited about the opportunity to have one of our own voices within those positions. If any of you receive care in Alberta, if you're at your doctor's appointment, feel free to tell them to vote in the election. If you feel comfortable, I'd love for you to tell them to vote for me. But just making sure that they're involved is really, really important. I think when you look at changing the healthcare system, it's important for us all to lift where we are. Patients have a voice that needs to be there. Communities have to have a voice that needs to be there. Patient advocacy organizations like FNHMA are really important to have around the table. And then making sure that you have leaders who make space and walk away from discussions that don't involve the right people is extremely important.
Well,
Yeah.
We're just so excited for you, Alika, and I hope you feel love and support from all across Turtle Island in putting your name forward. I want to thank you both for being here. Pam, you'll definitely be back. We know that. And Alika, to you, just a heartfelt thank you for your dedicated service to the wellness of First Nations across Turtle Island. We lift you up and stand shoulder to shoulder with you. On that note, I do want to thank, of course, all of our live Facebook partners, Micmac Maliseet News, Native News in Nova Scotia, The Wolf 95.7 in Fredericton, Nation News in Montreal, Element FM in both Toronto and Ottawa, NCIFM in Manitoba, Eagle Feather News, Alberta Native News, CJWE Calgary, CKLB, Yellowknife, Co-op Radio Vancouver, APTN News. Oh, you're the best. Thank you so much. And of course, Anishinaabeg Nation. Those radio stations, some of them have rebroadcast times as well. So feel free to check out when you can hear this again on your local radio station. So until next time, which is next Thursday, same time, we'll be talking about variations. Get your questions ready. Send them to FNHMA at ihtoday.ca. Stay safe, stay healthy, and know that you have a nation of love. Miigwech, hi, hi.